Assalamu alaikum. Welcome to our presentation. Today we are going to discuss that how it is decided that the patient presented with pain in the right lower abdomen should be diagnosed as acute appendicitis, because every pain in the right iliac fossa should not be diagnosed as acute appendicitis. Let's discuss how appendicitis should be diagnosed. Appendicitis is common in young males. It is common in white races. Fiber-rich diet prevents appendicitis, while less fiber diet increases chances of appendicitis. It is common in May to August, indicating seasonal variation, and is often called as epidemic appendicitis. Viral infection may cause mucosal edema and inflammation, which later gets infected by bacteria, causing appendicitis. Family history may be relevant in 30% of the appendicitis patients and in children with appendicitis occurring in first degree relatives. Obstruction of the lumen of the appendix causing obstructive appendicitis. Blockage occurs due to ficcolith, stricture, foreign body, roundworm, or threadworm. Including all these causes, ficcolith is the most common cause, and the organisms causing appendicitis include E. coli, Enterococci, Streptococci, anaerobic Streptococci, Clostridium welchi, and Bacteroides. In the past, there were different scoring systems to diagnose acute appendicitis. They include Albrado's scoring system, Kala modified Albrado's scoring system, Tazanaki's scoring system, Ripasa scoring system, and Anderson scoring system with 8 parameters. Nowadays, the most famous scoring system which is used to diagnose appendicitis is Albrado's scoring system with the abbreviation MANDRILS. It consists of different signs, symptoms, and laboratory investigations. They include migratory pain, anorexia, nausea and vomiting, tenderness in right iliac fossa, rebound tenderness, elevated temperature, leukocytosis with the count more than 11,000, shift to left with neutrophilia, making the total score of 10. When the score is 5, the appendicitis is not sure. Score between the 5 and 6, appendicitis is compatible, and score between 6 to 9, appendicitis is probable, while the score more than 9 indicates confirmed acute appendicitis. Investigations which are done preoperatively in a patients with a diagnosed acute appendicitis include complete blood count, urine analysis, pregnancy test, urea and electrolytes, C-reactive protein, supine abdominal radiograph, ultrasound of the abdomen and pelvis, contrast enhanced abdomen and pelvic CT scan. Other than this scoring system, there are two more investigations which are very helpful for the diagnosis of acute appendicitis. They include ultrasonography and CT scan abdomen and pelvis. Ultrasound findings of acute appendicitis with 85% specificity include non-compressible appendix of size more than 6 mm in the anterior-posterior diameter, hyperechoic thickened appendix wall more than 2 mm, target sign appendicolith, interruption of the submucosal continuity, and periappendicular fluid, while CT scan findings of the appendicitis with the sensitivity of 94 to 98% and specificity of 97% include enlarged appendix greater than 6 mm diameter, thickened appendiceal wall exceeding 2 to 3 mm, periappendiceal fat stranding, appendicolith, and fluid collections. By using these methods, different scoring systems, and other investigations, including ultrasonography and CT scan, and in pregnant women with MRI, appendicitis should be properly diagnosed and should be managed in a better way. Thank you very much.